I'll go ahead and invite the panelists to join me for this next session at the table. And while they're coming up, I'll go ahead and kick off the session. In this next session, we'll be focusing on a lot of the work that CDER has been doing with the Sentinel infrastructure. With Sentinel's integration into regulatory operations, opportunities are emerging to leverage its use as a resource for safety across the agency, as you heard much of this morning. To further explore these opportunities, key representatives from the Office of Surveillance and Epidemiology will highlight a few notable evaluations over the past year, and we'll get some initial reactions from their colleagues at the Office of New Drugs on how these evaluations could impact their work. So we're going to do this in a new way. Joint presentations on specific projects that have been used over the last year between the Office of Surveillance and Epidemiology and the Office of New Drugs at CDER. At the end of the session, we'll hold moderated Q&A with audience depending on how much time is left. As you can see, there's not even room for me at this table. It's a packed session. So what I'm going to ask everybody to do is I'll introduce everybody now, and then I'm just going to sit down in the audience. So as each presentation goes, just feel free for the next presentations to come up and give your presentation. So in terms of the introductions, we'll have, first we'll hear from Andrew Moschholder, is Medical Office in the Division of Epidemiology 1 in the Office of Surveillance and Epidemiology. Joined with Andrew is Mark Stone, Deputy Director for Safety for the Division of Psychiatry Products in the Office of New Drugs. Both Andrew and Mark will be speaking about their project, which is titled Incidence of Heart Failure after medications used for ADHD. As you'll note, Mark is sitting behind, okay, so never mind. But in the agenda, you'll see that we did have Tiffany Farshoni. Originally, Mark was supposed to present this, called in for jury duty, and so civic duty calls. But fortunately for Mark, he was able to get out of jury duty, so he's able to join us today, and Tiffany is off the hook. So after that presentation, we'll hear from Christian Hamp, who's Senior Epidemiologist for the Division of Epidemiology 1 in OSE. And with joining Christian is Jennifer Pippins, who's Deputy Director for Safety in the Division of Metabolism and Endocrinology at OND. And both Christian and Jennifer will be speaking about their project titled Prospective Surveillance of Myocardial Infarction after saxagliptin use. Next, we'll hear from Effie Awaruki, epidemiologist for the Division of Epidemiology 1 in OSE, as well as Mary Ross Southworth, Deputy Director for Safety for the Division of Cardiovascular and Renal Products at OND, and their project is titled Risk of Seizures After Ranexa Use. Finally, Mark Levinson is the Director of the Division for Biometrics 7 in the Office of Biostatistics under the Office of Translational Sciences. And Mark will give more of a broader perspective from the biostatistics perspective. So with that, I'll turn things over to Andrew.
Thank you very much. And I'm very pleased to be here today to talk about our analysis of heart failure and cardiomyopathy with ADHD medications. Let's see how. Okay, there we are. So, and on this slide, I want to acknowledge the collaborators from FDA and from Harvard Pilgrim Healthcare Institute. To give you some background, stimulants I think are familiar to people as treatment for attention deficit hyperactivity disorder or ADHD, and the current practice is that they may be administered for longer durations, often well into adulthood, as there's recognition that children don't necessarily grow out of the disorder. Then on the other hand, we know that illicit stimulant use is associated with development of cardiomyopathy as one of the consequences. And for therapeutic stimulant use, there are case reports of cardiomyopathy, but they're not really quantitative, systematically collected data that could help us evaluate that risk. So that motivated us to look in the Sentinel database to see if we could shed some light on this. And the hypothesis was that if cardiomyopathy is a long-term adverse effect of stimulant treatment, then we might see an increase in its incidence over longer durations of exposure or use. So long-term users might show a higher incidence of heart failure developing compared to initial users. So that was the premise. And so we undertook an analysis with the purpose of assessing the incidence of heart failure and cardiomyopathy among both adult and pediatric ADHD medication users who had no history of heart failure, and determining that over the course of time by duration of the medication use. So this was a modified L1 descriptive analysis. We were fortunate to have data from 15 Sentinel data partners for this purpose, and covering the time period of roughly 16 years. The patients we selected were users of either amphetamine products, methylphenidate products, or atomoxetine. Amphetamine and methylphenidate being classic sympathomimetic stimulants. Atomoxetine is a different mechanism of action, but it's still norepinephrine related. It's a reuptake inhibitor. We required that they had no ADHD medication or heart failure outcome within the preceding 183 days. We looked at 4 age categories, starting with children and young adults, and then up to 65 and over. When assessing continuity of treatment, we were pretty generous. We allowed a gap of up to 90 days. We thought that would reflect how the drugs are used. They're not always taken on a daily basis. They may be skipped during vacations or weekends, that kind of a thing. And we considered only each person's first treatment episode. To assess the outcomes, we used ICD-9 diagnostic codes for either heart failure or cardiomyopathy. You can see the codes listed there. We included both inpatient and outpatient diagnoses, but if it was an inpatient diagnosis, it had to be the principal diagnosis. And then we looked at the incidence during discrete periods of use, starting with the first 90 days of use, and then the second 90 days of use, in other words, days 91 to 180, and so forth, up to a duration of 3 years. So let's look at the results, and I'll walk you through this this slide. We had something like 2 million ADHD medication users in total, and just over half of them were in the youngest age group, as might be expected for that indication. And what you have on the vertical axis is the incidence rate per 10,000 person years of heart failure or cardiomyopathy diagnoses. And then across the horizontal axis are the 4 age categories, and within each age category we've graphed over the time periods the incidence of heart failure, and we have 3 separate lines, as you see, one for each type of medication. And so the things to observe here, first of all, as would be expected, the oldest age group has much, much higher incidence rates of heart failure than the younger age groups. The second thing to notice is that, if you will, our hypothesis was not supported. We were expecting kind of an uptick in the incidence rate with longer duration of use, and we don't see that pattern really for any of the age groups or medications. And then the third thing we saw, which was somewhat unexpected, in the oldest age category, and perhaps to a lesser extent in the next oldest, we saw actually a trend for a decline in the incidence rate over time. actually rather steeply. And so I'll have some comments about that in a later slide. But I want to point out there are, of course, some limitations. As I said, this was essentially an L1 analysis, so we did no comparison to incidence rates during periods of non-use. We didn't have accounting for potential confounders. And the other thing, we decided to combine, lump together, if you will, heart failure and cardiomyopathy. But if there was a trend specifically for cardiomyopathy alone, we might have obscured that. So the conclusions, first of all, there was no consistent increase in these events with longer duration of treatment over 3 years for any age or medication group. So the hypothesis we had was really not supported by these data. However, we did see the trend for higher incidence of heart failure earlier in the course of treatment in the older age groups. And in fact, close to 2% of patients 65 and over who initiated an ADHD medication developed new onset heart failure or cardiomyopathy within 90 days. So this trend would suggest what's called a depletion of susceptibles to the extent that patients who are at risk of developing heart failure in reaction to the medication are going to do that earlier in the course of treatment. It's a sort of unmasking, if you will, by the challenge with the medication. And there is some biological plausibility behind this. There's some older literature that suggests adrenergic agonists, as the sympathomimetic stimulants are, can be harmful in heart failure. And conversely, we know that beta blockers are used therapeutically in heart failure. Just to sum up Sentinel's role in the safety assessment, as I said, we had the hypothesis that cardiomyopathy would be a late emerging long-term risk of stimulant use. We didn't see evidence for that in the Sentinel data, but we did identify a new signal of heart failure with short-term use in the older patients. So there's some next steps we're considering to address this. We could think about analyses to explore whether there are particular risk factors that might lead some patients to develop heart failure with the medication. We're also considering looking at the randomized clinical trial data for ADHD medications in adults. This is an active area of development, so there's a growing body of data from randomized controlled trials in the adult population for this indication. And with that, I'll stop and turn it over to Mark.
Thanks, Andy. I think what this study is helpful with is really a better organized form of pharmacovigilance. That our principal concern would be particularly young people starting on these drugs and then showing up with cardiomyopathy after a certain period of time. In the past, we would have to rely on AIRS and on spontaneous reporting, and without a good sense of the denominator and or even a sense of counterfactual, whether this heart failure would have developed in the absence of the drug. Here, as I said, there was no control group, but at least we have the time pattern and things like that to specify. And the comparisons, I mean, there are some necessary weaknesses here. Most importantly, that we're looking at initiators. Most of the action is over in the older patients, and an initiator of a stimulant at age 60, 65, or 50 is not the typical person we think about in terms of chronic stimulant exposure in the context of ADHD. In fact, probably a lot of these patients are have narcolepsy or refractory depression and other indications. On the other hand, what you're doing is that you're getting a group that is more susceptible. And even if it's not a typical group, in some ways it's kind of like an experimental population there. You can see what the drug can do, and the drug did something, the drug's not very surprising in the sense of this depletion of susceptibles and basically revealing heart failure in patients that may have been compensated, and the stimulants caused them to decompensate because of quite possibly because of exposure to greater degree of beta agonists. And the other thing I would note, kind of in passing, is that they didn't include atomoxetine, but atomoxetine is almost never used in older patients, and you can see it was a very uneven line for that. So we're kind of narrowed in a different situation. So I think it's a step ahead of what we would have in the past, but it clearly doesn't come near to giving us a very solid answer to the question. I would say, though, it does kind of put a lid on what we'd expect to see, that there's not some hidden epidemic, and I think there's some comfort in that.
Good afternoon. My name is Christian Hemp. I will talk to you about an analysis that we did on surveillance of AMI events in new users of saxagliptin. This was a very extensive project that couldn't have been done without the input of many individuals. I would like to specifically mention Darren Toe and Bruce Fireman, who led the project on the Mini-Sentinel side, and Marsha Reichman and Dave Graham, who were instrumental on the FDA side. Why did we conduct this study? In about 2009-2010, FDA identified the need to produce infrastructure for prospectively monitoring the safety of new drugs. A new drug came along, saxagliptin, which was the second DPP-4 inhibitor. It's an oral anti-hyperglycemic agent approved in 2009. The first DPP-4 inhibitor was sitagliptin, approved in 2005. This was chosen to be the first new molecular entity to be prospectively monitored in Mini-Sentinel. You may or may not know that many new antidiabetic drugs are approved with a PMR for a clinical trial, cardiovascular outcomes trial. That was also the case here. So this analysis was designed to complement this cardiovascular outcomes trial. The idea was that Mini-Sentinel could provide interim safety data about saxagliptin while the trial was still ongoing. Also, rather than conducting a retrospective analysis, a purely retrospective analysis, having this prospective surveillance could help us identify safety issues earlier. This was a protocol-based analysis. Protocol was published in 2010, and subsequent revisions were also publicly posted. We used a new user cohort design, and we included 4 head-to-head comparisons: saxagliptin with sitagliptin, which is the first DPP-4 inhibitor, with pioglitazone, with second-generation sulfonylureas, and with long-acting insulin. These were separate comparisons. We started following patients after they initiated a new drug, meaning they were without their drug for at least 365 days. In that baseline period, we ascertained covariates, inclusion-exclusion criteria, and we followed patients until they had acute myocardial infarction or were censored for any of the listed reasons. We conducted 2 separate methods of covariate adjustment. One was propensity score matching, the other one was disease risk score stratification. These scores included patient demographics, medical history, medication use, cardiovascular risk factors, other anti-hyperglycemic treatments, or health services utilization measures. We used Cox proportional hazards models, and we stratified our patients into 3 groups. So we either had all patients or those with or without prior cardiovascular disease. Now, everything I mentioned so far could also describe a retrospective cohort study. But what was different in our analysis is that we did a prospective analysis, a prospective sequential analysis. Now, what is that? Think of it as an updated data analysis as the data accumulates. So rather than waiting 5 years and then analyzing all data, we analyze data in several steps, time increments if you so want. This illustration, think about time increments as 6-month periods in which we analyze the data. So in the first time period, we would start identifying initiators of saxagliptin. Then we identify initiators of a comparator drug, and we propensity score match them. Then we get a measure of effect for acute myocardial infarction. In the next time increment, the next 6 months, we would find new users of saxagliptin again and new users of comparator drugs. But we keep following patients who were identified before. And then we update our effect estimate. And then we do the same in the next time increment. We find new patients, but we keep following the old patients. So we accumulate more individual person time. We keep doing that. And what you can see here is that the measure of association is supposed to stabilize with more events observed. You see that the curve kind of stabilizes and the 95% confidence intervals become narrower towards the end of the analysis. So here's what we actually did. We conducted 7 sequential analyses, so not quite as many as I illustrated earlier. We had what's called an alpha spending plan that keeps the overall chance of a false positive below 5%. That is necessary because with those 7 different analyses, the chance of false positive findings increases. However, we only did that for those 7 sequential analyses. At each of those steps, we did many additional analyses. So we had 2 methods of covariate adjustment, propensity score matching, and disease risk score stratification. We had 4 comparisons, those 4 antidiabetic drugs, and we had 3 strata of cardiovascular disease. Each of those is an analysis that generates a chance for false positive. And it's important to keep in mind that we only adjusted for the 7 longitudinal analyses, but not for the 24 at each step. These are our baseline characteristics. I will not go over them in detail. What we found is that the comparisons of saxagliptin and sitagliptin and those of saxagliptin and pioglitazone were fairly balanced, not so much when we compared saxagliptin with sulfonylureas or insulin. We had about 82,000 saxagliptin inhibitors at the end of the study, and there were more available in each comparator group. These are the findings for saxagliptin versus sitagliptin. Our data started in August 2009. The final look was in August 2014, and we had several looks in between, or several analyses. This particular analysis did not show any concerns between saxagliptin and sitagliptin. In the comparison between saxagliptin and pioglitazone, we had a signal. The 5th analysis produced a hazard ratio of 1.63 in propensity score matching, not when we stratified on the disease risk score, which is the blue curve. I will come back to that. In the analyses of sulfonylureas and long-acting insulin, there was no evidence for higher risk associated with saxagliptin. Now, looking back at that signal that we had with pioglitazone, in the 5th look, we had a hazard ratio of 1.63. However, when we followed patients longer and added additional new users, that attenuated. So the final look was 1.17. Similarly, as I mentioned before, in the disease risk score stratified analysis, there was no such signal. So what could be possible reasons? It is possible that the risk of AMI really was higher for saxagliptin versus pioglitazone. There could be residual or unmeasured confounding, or there could be errors in data or analytic code. However, none of these would explain why it only happened for pioglitazone, only in the 5th look, only in the propensity score analysis. So it is possible that this is a false positive or a chance finding. We concluded that we found no strong evidence to suggest a higher risk of AMI in saxagliptin users compared to users of sitagliptin, pioglitazone, 2nd-generation sulfonylureas, or long-acting insulin. So what about that clinical trial? In 2013, this clinical trial was published. That was a post-marketing required cardiovascular outcomes trial. And I would like to compare them side by side. So one comparison, of course, It was a clinical trial, randomized. Our study was observational. We could have residual confounding, especially with regard to lifestyle factors that are incompletely ascertained in Sentinel. The comparator is different, so they tested a different hypothesis. In the clinical trial, it was placebo. We used active comparison. Our study had about 10 times as many saxagliptin initiators. But this is also a shout out to the clinical trial. This is a very large cardiovascular outcome trial with 8,000 patients exposed to saxagliptin. The length of follow-up was substantially shorter in our study compared to the clinical trial. It's also counter to conventional wisdom, but that's what we saw here. The clinical trial, even though much fewer initiators of saxagliptin, had more AMI events. The clinical trial was enriched for patients at high cardiovascular risk, and average follow-up was longer. So this could have created more events here. Clinical trial was intention to treat. We analyzed as treated. However, the findings were comparable. In the clinical trial, the hazard ratio was 0.95. In our analysis, you see a range of hazard ratios here, but that's throughout all the different comparisons that we did. When we look at the end of analysis results, we find that we generally agree with the clinical trial, and those are also our conclusions. What is the importance? We had results from first looks available before the clinical trial was published. We had real-life head-to-head comparisons, and also this established infrastructure for prospective surveillance in future studies in Sentinel. Thank you.
Good afternoon. I'm grateful for this opportunity to comment on a project that I think is a really exciting part of the history of Mini-Sentinel growing up into Sentinel. To start off with, I think I would be remiss not to note the enormous significance of this project as an early Mini-Sentinel project, and in fact as the first example of a new molecular entity being prospectively monitored using Sentinel. So enormous significance with respect to the evolution of methodology that I think will be really critical as Sentinel continues to grow and we think about its uses in a regulatory framework. I thought it might be helpful to highlight what I see are a couple of key strengths of this project, and then also the other side of the coin, a couple of important limitations that I think are critical to acknowledge as we move forward in trying to continue to evolve our methods. So with respect to this project and a couple of key strengths, first and foremost, what I think is really remarkable was this project's design with respect to sequential analyses and really the ability that provided to provide prospective monitoring. It's very important to note that saxagliptin was only the second in this new class of drugs, the DPP-4 inhibitors, and also a drug that was really fairly early on in FDA's experience with respect to monitoring for cardiovascular safety in the post-marketing setting in this particular space, the diabetes space. So in that setting, having a tool that could potentially provide interim looks at safety moving forward and prospectively, I think was an incredibly important development in the capacity for Sentinel to really speak to the issues that are important to FDA as we look at post-marketing safety. So in addition to the capacity for sequential looks and prospective monitoring, a second strength I find is really the use of multiple comparators to provide a rich view of the safety profile of this particular drug. So saxagliptin was compared to a variety of comparators, 4 groups. And with respect to the diabetes space, clinicians are making decisions between one class and another class of drugs. So these are really relevant questions to clinicians as they're trying to determine, do they initiate with a DPP-4, do they initiate with a different class of anti-diabetic medication? So I think that illustrates the potential for Sentinel to ask really relevant clinical questions. So those are some of the strengths. Of course, on the other hand, there'll always be limitations, and 2 that I like to note sort of correspond to these concepts of sequential analysis and then also choice of comparator. So with respect to sequential analysis, I just want to highlight some of the perils inherent in looking at interim safety data. So it's noted in the results for this particular project that in one of the sequential looks, there was a hit with respect to the comparison to pioglitazone. So the question is, as a regulatory agency, what do you do with that? what is the extent to which you think that signal is potentially real? And in that setting, how does one actually handle that with respect to transparency, informing of the public, and influence on regulatory decision making? So if we continue these projects with respect to prospective monitoring and sequential analyses, we'll really have to grapple with how do you make decisions based on limited information that may not be fully mature. The second limitation I'd like to potentially know is, again, with respect to the choice of comparators. So there is no single perfect comparator in this setting, and each of the various 4 classes of drugs, while none of them are thought to have a particular strong safety signal with respect to cardiovascular disease, none of them have been fully characterized themselves. So how do you know what's the appropriate comparator pick to really define the cardiovascular safety profile of the particular drug of interest? So those are some of the limitations. But that being said, I think it's a terrific example of opportunities moving forward to continue to engage in post-marketing surveillance.
Good afternoon. My name is Efe Woruke. I will be presenting the results of a Sentinel-led analysis that examined the risk of seizures associated with ranolazine, trade name Ranexa. Before I begin, I would like to acknowledge the following individuals on this slide from the FDA, as well as the people from the Harvard Pilgrim Healthcare Institute. Ranexa is an oral drug given twice daily for angina. Angina is chest pain caused by insufficient blood flow to the heart. The possible pharmacological activity of Ranexa is related to its effects on the sodium channels which are present in the cardiac, central, and peripheral nervous systems. The safety issue of interest, seizures, were first identified during the preclinical trials prior to its approval in January 2006. Convulsions, sedation, and other neurological events were observed at high doses of Ranexa. This led to the labeling language, including these identified events, at its approval. In January 2013, the FDA identified the case report of neurologic events. This led to initiation of post-market surveillance in the first data. And the completion of this post-market surveillance resulted in updating the label in November 2013. The language described the onset of neurologic AEs associated with increased dose of Ranexa. In February 2016, there was continuous surveillance, and this resulted in identifying the safety issue of seizures in the first data. This is what has led to the initiation of this signal assessment. So this slide summarizes a basic description of the first data. Among the 11 seizure events found in the first data, 7 of them occurred within 10 days following Ranexa exposure. 1 occurred 14 days after, another 38 days after, and for 2 cases, there was only a description of a short time after initiation. The median age for these cases was 78 years, and 64% of seizure events were associated with hospital stay. When Ranexa was withdrawn, 73% of the cases resolved, meaning there was a positive de-challenge, and approximately 36% of the cases reported chronic renal failure with the reporting of the cases. So temporality, the de-challenge, coupled with the severity of the outcome in terms of the hospital stay, heightened the need for further evaluation of this signal. And so what was our objective? The Sentinel objective was to investigate whether Ranexa use was associated with an increased risk of seizures. So as I earlier discussed, from the first data, the signal was generated from isolated reports. Now, within the Sentinel data, we were tasked to examine whether seizures were temporarily associated with the initiation of Ranexa. In terms of study design consideration, Ranexa presented a unique challenge. The American Heart Association recommends Ranexa in circumstances where beta blockers, calcium channel blockers, and nitrates are no longer effective or not tolerated. Therefore, selecting any of these drugs as comparator for the study would result in creating a patient population with different characteristics that may not be adjustable in the claims data. Therefore, we embarked on using the self-controlled risk interval design, which is a level 2 Sentinel modular program. Basically, the design looks at exposed patients and compares two periods where there's a high risk shortly after exposure to a control window where we hypothesize that there's a lower risk of the event. This decision was further strengthened by the FAIRS data, which I just presented earlier on, that showed a temporal association between Ranexa exposure occurring within a short time after exposure. The self-controlled risk interval design is also best suited for acute outcomes and also is able to control for time-invariant confounders. The methods. We included data from 12 health partners from January 2006 through September 30th, 2015. We defined the cohort as patients 18 years or older with at least 183 days medical and drug coverage. Now, within this source population, we defined two cohorts. The Ranexa cohort defined as new use Ranexa, which was defined as no Ranexa use during the 183-day before the first use. And we required no seizure, no epilepsy, and or no anti-epileptic drug during this baseline period. The second cohort, the Ranexa with AED, was defined similarly, but we allowed the use of anti-epileptic drug during the baseline period. The first valid 30-day prescription plus a 2-day extension period formed the observation window for analysis. This slide provides a schematic diagram of how the study was set up. As I said earlier on, the observation window began from the date of prescription through the 30th day plus a 2-day extension window. The high-risk interval was defined as day 0 to day 10, which is in accordance with what we observed in the FAIRS data. The control window began from day 11 through day 32, where we hypothesized that there would be a lower rate of seizures. We then compared the number of seizure events in the risk interval to the number of seizure events in the control interval. Seizure events were defined by ICD-9 codes shown in this slide for epilepsy, convulsions, myoclonus in the inpatient or emergency department discharge files. We looked at the following populations of interest. Ranexa users defined as Ranexa use with no epilepsy or no seizures or no AED at baseline. Ranexa users with AED, which were defined as Ranexa users with no epilepsy or seizure, but the use of AED at baseline. We also examined the following age categories: 55 to 64, 65 to 74, and 75 plus. And we looked at patients with renal and liver, pre-existing renal or liver disease, defined as the presence of a code for renal or liver condition at baseline. This slide summarizes basic descriptions for the cases found in the FAIRS data, as well as those we identified in the Sentinel data. Among approximately 58,000 Ranexa users, we identified 28 seizure events among the Ranexa users and 11 seizure events among the Ranexa with AED users. This slide also highlights the prominence of more cases within the age 74 plus, as well as a high proportion of renal patients among the Ranexa users. The slide here presents the distribution of the number of seizure events during the high-risk window, denoted by the red bars, and the control interval, denoted by the green bars. The tables underneath gives the number of seizure events in the risk window and the control window. We calculated the relative risk among the Ranexa users to be 1.1, including the null, with the confidence interval, and for Ranexa users with AED as 2.4, that also include the null. For the populations of interest, we did not find any significant results or significant increase in seizure risks shortly after exposure. However, we did note a slight increased risk, which was not significant in the 65 to 74, as well as those with pre-existing renal disease. So in summary, the seizure rates within 10 days of Ranexa initiation is rare and does not appear to be higher in days 11 to 30. For Ranexa users with a history of AED, we found a non-significant 2.5-fold increase in seizure risk. It should be noted that the AED population is a mixture of patients with epilepsy and those who use AED for other conditions such as pain. Therefore, future studies examining the role of epilepsy or polypharmacy on seizure risk would have to be evaluated. We also do find slight increased risk, although not significant, among RENA as well as older patients. This study exemplifies the role of Sentinel in safety assessment. As I earlier noted, we identified the seizure signal in the FAERS data, and then there was a need to further refine this signal, which was done in the Sentinel data. Sentinel afforded us the ability to quantify risk among Ranexa users, as well as identify populations for future evaluations. Further signal refinement in Medicare, which has a better representation of older population, is underway. Thank you.
Hi, good afternoon. So just to provide a little bit of clinical context around the use of ranolazine, as Evie said, this is a drug that's used when beta blockers or calcium channel blockers are not working anymore or they're not tolerated. So I consider people who get Ranexa to be probably sicker, on the sicker end of the angina population. So one might expect seizures to have some sort of significant background rate in that. So what we were faced with was a small, interesting case series of seizures that sort of seemed to happen temporally to initiation of Ranexa. We also had some other sources of data. There's some animal data that shows some neurological toxicity at real high doses of Ranexa. But we did have the luxury of 2 large randomized controlled trials of Ranexa in a patient population that's very close to what is usually treated with Ranexa, so people who have sort of inoperable coronary artery disease. And in those, if you lump those 2 trials together, the incidence of seizures in the Ranexa group versus placebo group were very similar, and the incidence of seizure was rare. You had sort of some of these sort of conflicting streams of data telling you, some suggestion of causality, but then this really nice database that's usually not available showing you that there's not really much difference between the 2 groups when you looked at it in a randomized setting. So it was really nice for us to be able to use ranolazine to sort of explore quantitatively some of the signals that were shown up in FAERS. So OND and OSE confront signals like this all the time in FAERS, where you see sort of some suggestion of causality, but you have some suspicion that there's a background rate. So a dozen cases in FAERS, 24 cases in FAERS may not convince you that there's a causal relationship between the event. So a sentinel analysis gives you some idea of maybe a background rate or something to compare it to, and it also enables you to have a denominator, so you can see, is this a commonly occurring event or an infrequent event. And a lot of times when we're analyzing signals like this, we don't have the luxury of having randomized control trials like we did in this case. That is going to be probably your gold standard. That's where you're going to go to for your most rigorous assessment of causality. So to overcome a non-imbalance in a large randomized data set, you're going to need a little bit more than just a suggestive case out of FAERS. So a little bit more about like how you might apply this to how we do pharmacovigilance in general. The fact that Sentinel can generate background rates of events that happen in sick patients is very valuable, because it helps us sort of interpret some of the signals that are coming out of FAERS. So I think we should probably move towards trying to collect a bank of these background rates as we sort of encounter signals that we identify out of FAERS, so that we can get an idea of how common those events are. Again, Sentinel can provide a comparative data with denominators, so that you can understand how frequent or rare the event is, which helps us when it comes to regulatory decision making. Should it be labeled? Where should it be labeled? Does it need a warning, or can it be labeled just as an adverse reaction? The more data, quantitative data that we can get, the better for making those sort of regulatory decisions. And I personally think when we do these FAERS analyses and identify these interesting case series, we should be looking at Sentinel and seeing if it can be assessed in Sentinel every time. I mean, this is a piece of data that we have access to, and there's really no reason why we shouldn't be looking at this more frequently. It helps the Office of Surveillance sort of incorporate looking at that and assessing feasibility of Sentinel as we do it more and more, and it also helps the O&D side, who sort of has to make the regulatory decision about labeling, use the system a little bit more so that they understand the methodology and can sort of get more well practiced in taking data from Sentinel and using it to make regulatory decisions. So I really enjoyed working on the project and look forward to working on some more.
Hello. I'm Mark Levinson. I'm a director of Statistics Division at CEDAR that deals specifically with drug safety, both in the pre-market and the post-market. We work with both the Office of New Drugs and the Office of Surveillance and Epidemiology, but we're separate, so we perhaps have a unique perspective. We're also very much involved in the post-market requirement world, too, so we see a lot of PMRs outside of Sentinel that also gives us a good perspective. We've been involved with most Sentinel methods projects and surveillance projects, so I think the panel's already made a lot of good observations, so I'll just include some that maybe I haven't heard. The saxagliptin project was certainly a very large undertaking, but we learned a lot from that. And I think if you compare it to what we had available before Sentinel, where we would issue PMRs to maybe address a similar question, I think we're in a much better position. We have more data, we have validated outcomes, validated programs, and now with the modular programs, we can do this much quicker. So that was a big learning exercise. It was valuable in itself to give us, safety information, but I think we learned a lot from that, and we're certainly in a better position than we were 5 years ago. Looking more towards the future a bit, Rich Platt mentioned the integration of CMS. I think this is going to be somewhat of a game changer. Some of the limitations we've experienced in Sentinel over the few years had to do with how many people are actually taking these new molecular entities, because sometimes the uptake isn't very large. With the CMS integration, we'll have a population that takes a lot of drugs, and we've been able to answer questions using CMS, mainly led by David Graham at FDA. So we were able to address a lot of important safety questions, but I think bringing that into Sentinel, we might be able to do that quicker and apply it to a lot more drug areas. So I see a lot of potential with the integration of CMS. I heard several comments about pharmacovigilance. Mark Stone mentioned that he thought that was very kind of in line with pharmacovigilance, what we learned from that project. And I think that was, excuse me, that was the use of a simple program to get simple counts, but it gave us pharmacovigilance information. Moving forward, you heard we're developing tools like TreeScan and other tools that I think will allow us to do even more thorough jobs of pharmacovigilance. And I think Sentinel has a lot of potential in that area. And finally, I was glad to hear Rich Mashinsky talk about that methods development shouldn't be over. There's, I think, a lot more uses we can make of the Sentinel data. In particular, I think it's important to understand the biases and precision in Sentinel and how we can use methods to better reduce bias and reduce precision. So, thank you.
Great. Thank you to all of the presenters. These were terrific examples of how the Sentinel infrastructure and the system itself can accommodate different study designs, different analytic techniques that are needed depending on the safety risk of interest, the therapeutic area, the nature of these things, particularly the need for like a self-controlled case interval design. And a lot of good examples of potentially how this system could be useful in the setting of post-market requirements. Really good examples. And all of you have sort of made the inference that the analytic tools and the data infrastructure have been helpful to better understand the potential for these risks in the specific projects that you talked about. Before I open it up to the audience for questions on these projects, just one general question to panelists on as we think about this system being used potentially more frequently for post-market requirements, we heard this morning about potentially through IMEDS or through other avenues. What would be your sort of recommendation based on what you've learned in your study for increasing the volume of these kinds of safety assessments in the post-market requirement setting? So anything that you learned that you would say, if you were to go back and do it again, like, gee, I wish I knew that, or if I could make an improvement to process, or thinking about these things as you go into the study, what would be your recommendation?
I mean, I think I said this in my comments, but we should be incorporating all of these data streams, including Sentinel, into our pharmacovigilance, and not just looking at like a case series out of FAERS. We need to be looking at Sentinel more regularly. It should be part of the data that you grab. You should be data mining FAERS. You should be analyzing cases out of FAERS. You should be looking back at any controlled data that you have, and looking at Sentinel to see what's happening in the real world. So I just think we need to use it more.
Okay, great. Jennifer?
I think one major issue moving forward is just the timeliness. So I think as Sentinel continues to improve with respect to the timeliness of the information it can provide, its utility with respect to surveillance in the post-marketing space will be increased. So in diabetes, we have a number of new drug classes, NMEs, and in recent years, we've had some significant safety issues emerge, even fairly early on. And once a drug has been introduced, ketoacidosis comes to mind with the SGLT2 inhibitors. So to the extent that we can have really timely information, that will really improve Sentinel's capacity to be a useful tool.
Great. Mark?
Yeah, I would just be a little more cautious in the sense that when we promote this, we basically accept the standards that the system gives us rather than, or the information that the system gives us rather than designing the query for ourselves. That it's like the saying, when what you have is a hammer, everything looks like a nail. And I think if we end up with kind of very standardized analyses and input, I think we will look at things within the context of that analysis, and let that analysis determine the questions and answers rather than trying to get a better understanding of what may really be going on. I think there's a tendency to be a bit pre-programmed that I would be cautious about.
Okay. So any questions from the audience on these projects or comments on them? Okay, as you're thinking, I've got, so Christian, you sort of piqued my interest with the comment on the length of follow-up that you saw in the Sentinel data versus what was in the trial, and it was counterintuitive, as you pointed out. Any sense on sort of what the driver was for that?
Yes. I don't know the breakdown for reasons of censoring for our particular study, but what we see in similar studies is that the two main drivers are end of eligibility, that usually means end of the study period, or end of insurance eligibility. On average in Sentinel, individuals are with one healthcare provider or one health insurance for about 2 to 3 years. That can be very different depending on inclusion criteria. In studies on diabetes, it can be longer. Diabetic patients tend to stay with their insurance longer than the general public. So that is one limiting factor. The other limiting factor is just people stopped using a drug. And that is probably responsible for almost half of the censoring. So even chronically used drugs are not used for years and years.
Okay, great. So just continuing on this line, we did hear this morning about future continued investments in methods, tool development, and also data resources. So more clinically enriched data. We heard the Medicare data as being will be a huge advantage in terms of being able to capture more comprehensively a large segment of the population that may not be well represented in traditional commercial claims data. As you're all thinking about and getting to Mary Ross's point about this should be done more often and more frequently. What do you, in terms of making that happen, any particular emphasis from your perspective on either like more clinically enriched data or methods in terms of analytic tools? Where would be your thoughts on where the most emphasis needs to be?
I won't speak to methodology, but I will echo the need to have CMS data in there. What we found is the mini-sentinel population is a commercially insured population, so it's younger, it's healthier, and you'll see that in rates. You'll see differences in rates in sentinel. They'll be lower for some things. So being able to have an older population will definitely increase our ability to look at some of these signals.
Okay. Any other comments? No. Okay. So I think that takes us essentially to the end of this session. I'd like to thank our presenters and panelists for wonderful presentations as really good examples of the capabilities of the system. So thank you very much.